His graduation was in India, and then he went on for higher qualifications to US, and he did his internal medicine at Mount Sinai Medical School, and he's trained hematologist and an oncologist at Cleveland Clinic. He has got keen interest in translational research. That is what we are doing here at AIG. And now we will hear from him what the kind of translational research that he is doing in Vanderbilt Medical School. He's passionate about genomics and drug development, mainly focusing on blood cancers. I welcome Dr. Ashwin Kishatagari, and thank you so much for accepting our invitation, and we look forward to hearing to your.
Thank you so much, Dr. Shashikala, for this kind invitation and facilitating the entire process, and even to my close friend, Dr. Pradev, who first introduced to me to everyone, and Dr. Reddy for inviting me to give a talk and talk about some of the work we are doing at Vanderbilt, as well as potential for collaboration in the future as well. So my topic is the tipping point, how genetics is making healthcare personal. I shamelessly stole this title from my favorite author, Malcolm Gladwell. He wrote a book called The Tipping Point. He liked the title so much that he released the next book 20 years later called The Revenge of the Tipping Point. I think the tipping point, the core of the idea is that there are small things that happen over the period of time, and eventually there is a big revolution that happens. I think that's what's happening right now in genomics. Back in 2000s, there was a lot of talk about genetics, genomics, but that kind of died down eventually because of how expensive it is. But that has changed over the past 5 to 6 years, where the cost of sequencing has come down substantially, where right now it's being broadly used. So I think this is a kindly timing of this talk, because right now, I don't know if you guys heard, just a few days ago, our PM Narendra Modi has announced Genome India sequencing was released of 10,000 genomes. So this is sort of a timely topic of discussion. So here are my disclosures. As Dr. Shashikala Madam said, that I work in drug development. So drug development involves a good partnership with pharma. So I work very closely with pharma in developing new drugs for leukemia mostly. Along with that, I have a very strong interest and passion for education as well. That's why, along with my close friend, I run a podcast called Blood Cancer Talks. It's mostly catered for people in the medical school, as well as internal medicine residency training, who are interested to learn about blood cancers, as well as it catered to all the community oncologists, where there's too much information out there, and we try to break it down into palatable, easier bits and pieces when you're driving for work. So please have a listen to it. If you like it, please let us know, and we want to hear more feedback from all the trainees. So as Dr. Madam said, that I'm from Vanderbilt University Medical Center. It is located in the heart of US, in the southern state of Tennessee. It's called Nashville. That's where Vanderbilt is. And Nashville is, there are a lot of landmarks in Nashville, but this is the Vanderbilt University. Attached to the university is the medical center here, which is very well known for a lot of huge developments. And I was told that when I first visited Vanderbilt, it is where the first open heart transplant happened as well, and it's one of the biggest open heart transplant in the entire world. It's also known for this Parthenon, which is an exact replica what's there in Greece. And we are also known for our music. It's called the Music City because a lot of people, including Taylor Swift, was made her music career in Nashville, singing in all this Nashville local pubs. And we are also known to a lot of tourists for this something called pedestal tavern, where you drink your beer and you pedal, and you can visit the entire Nashville using that pedal tavern. So with that, my main motivation for this talk is, if genome sequencing were readily available, how can we use genetics to make healthcare personal? I think whenever we think about genetics, I think the first thing that comes to our mind is the big three. I call them. One is the familial hypercholesterolemia, and the other one is the familial breast ovarian cancer driven by the BRCA mutations, and then the Lynch syndrome, which happened with the mismatch repair genes. These are the three things that come into, that were trained during our medical school as well, that you need to know these three things that are driven by genetics. But I think the big question that comes is, should we test all the people out there for these sort of familial hypercholesterolemia as well as the breast cancer? I think I would say that no, I think we are not there yet. Lot of the times the Mendelian disease mutations are driven by a family history. You have a family history, then you have the phenotype. You test for them and you detect the particular genomic abnormality. But that's what normally happens in the general population. If you screen general population, only about 20 to 50% have the particular genomic abnormality, but majority do not. Other reason why we use genetics a lot is something called to diagnose rare diseases. So this is it's called Undiagnosed Disease Network, which is in US, where if a particular patient with a particular symptoms or group of symptoms does not have a labeled condition, then they are referred to these networks, Vanderbilt being one of them, where after a thorough history and thorough examination by multiple consultants, and they still are not able to label what the person has, then we do a whole exome sequencing of their genome to identify if there's a particular variant where we could act on. So this is one of the way where genetics play a huge role. Right now, when it was the first report of Undiagnosed Disease Network was released, they have identified actually 40 different disease types using a particular genomic abnormality. So I think it's a highly successful network. They have also hopes to expand it beyond US as well. But my talk today is, right now we use genetics as a last measure, but what if the genetics can be used as a first test instead of the last test? I think that's where the somatic mutations, which are the mutations you acquire as you age, play a big role. And the rest of my talk today, I'm going to talk about what are somatic mutations and how they are important and why do we need to care about them. We all know that as we age, a lot of things change, and some things do not, but our genome definitely changes. I think the most important thing is the telomeres, which are the end in the chromosome, they shorten. That's one thing. And there's another phenomenon called clonal hematopoiesis, which is the basis of rest of my talk, which is as we age, our hematopoietic stem cells acquire a particular mutation, which is not something you are born with, it's something you acquire as you age. And there are various factors why you develop a mutation, and that is something we can talk in subsequent slides. That is one other reason why we need to study the somatic mutations. So this is clonal hematopoiesis. It's right now termed as the pre-cancer. So there is healthy blood here, and then there's a random mutation that happens as we age, and is mostly seen in people who are older than 50. And there are some studies showing that even it happens earlier than 50, but the prevalence is mostly more than 50. And that can predispose an individual to development of a blood cancer. It is driven by somatic mutations, which are the single nucleotide variants that happen. One of the common is the TET2 mutation. As some folks in the audience might know, this is one of the leukemia driver mutation as well. We see in acute myeloid leukemia as myelodysplastic syndrome. Along with the single nucleotide variants, there are chromosomal changes as well, and even chromosomal changes are used in classifying the risk status in acute myeloid leukemia. But we see this chromosomal changes at least 10 to 15 years before development of AML. This was quite a big surprise in the field that we can detect this genomic abnormalities 10 to 15 years before development of acute myeloid leukemia. And these are the two different types of variants we normally see. So this is my outline of my talk. We'll talk about the diagnosis of clonal hematopoiesis, and then subsequently we'll talk about prognosis, and then we'll talk about mechanism, and finally to finish off, what is the management. We as a clinicians here, I think management is a very, very integral piece of any disease. So there's not a lot much, but I think there are some speculations I can make about management. I think the first important piece is the diagnosis. As I mentioned earlier, the prevalence of CH is mostly patients in above 50. I shouldn't say patients, I should say individuals above 50. So this is a graph from All of Us, which is a precision medicine initiative in US. It was started by Barack Obama back in 2012-2014, where he signed this All of Us initiative, where about the goal is to sequence 1 million US individuals with different genetic backgrounds, so that we can understand what are the variants that can predispose this individual's development of all health conditions, including coronary artery disease, cancer, as well as liver disease as well. This is an exact replica of what we call UK Biobank. UK Biobank was started much earlier. It was started in 2000, and they have so far sequenced 500,000 individuals with their medical history aligned with those the sequencing results as well. And right now, researchers throughout the world have used these UK Biobank resource to identify a lot of genetic variants which can predispose them individuals to various medical conditions, as well as they have used this resource to development of new drugs as well. So pharma is very well vested in these huge biobanks. And All of Us is something which has started recently, so we don't have the longitudinal data yet. But in these two biobanks, if you look at the prevalence of clonal hematopoiesis, it goes steeply high once you cross 50. And if you look at anyone above 70, the prevalence in the entire general population is close to 10%, which is very, very, very high. It's as close as hypertension as well as hyperlipidemia out there. So I think that's what this is going to be a very important topic in the years to come. And hopefully in the subsequent slides, I can convince you guys that why it is important and why you guys need to care about clonal hematopoiesis. So what are the mutations that drive clonal hematopoiesis? So these are the different mutations. As I mentioned, TET2, which I showed in the earlier slides, which is a somatic mutation that can happen in AML or myelodysplastic syndrome. There are other mutations as well, including DNMT3 and ASXL1, which they constitute about 75% of all clonal hematopoiesis mutations. But there are other mutations as well. But in general, if you look at it, about 25 different mutations, which comprise about 90 to 95% of all clonal hematopoiesis. Recently, in 2022, the World Health Organization, which is the blue book we use for diagnosing all blood cancers, and this is a standard reporting format. Whenever a pathologist looks at the bone marrow, he has to comply using the WHO classification. So in 5th edition, which was released in 2023, they included clonal hematopoiesis and gave an official definition as well. And this is the official definition of CHIP, which is clonal hematopoiesis of indeterminate potential. When they first coined this term, we don't know what the potential of it is. That's why it's called CHIP. But slowly, I think there is a lot of consequences, which I'm going to discuss in subsequent slides, of clonal hematopoiesis. So this is the definition. It is driven by a myeloid driver mutations, which is what we talked in the previous slide. The mutations which we normally see in AML MDS, which are detected 10 to 15 years before they develop. And they classified a particular variant allele frequency. I think this is important to talk about because a lot of people can have random mutations in their stem cell compartment. That it does not mean that everything is significant. A particular threshold need to be defined, and that threshold is 2% is what WHO used. And they don't have any other blood abnormalities. So these are the people who have the mutations with a particular fraction in their blood, and they don't have any blood count abnormalities. And a related condition is called CCUS, which is a clonal cytopenia of undetermined significance. This is the same CHIP with low blood counts. So anyone with a low blood counts, if they have a CHIP mutation, and they are called clonal cytopenia of undetermined significance. And both of these conditions can increase the risk of development of blood cancer. And this is the official WHO paper, which came out in 2022, but the blue book of WHO came out in 2023, where they are formally recognized as a precursor states. This is very similar to the polyps you see in GI cancers when you're trying to, colon cancer especially, the polyps you see, it's very analogous to it. And in myeloma world, MGUS is also very analogous to CHIP and CCUS. Now, how do we find CHIP? Normally, any healthy person, if they get their sequencing done by set of genes, and we detect there is a presence of a particular variant, and that variant is classified using something called variant allele fraction, which is nothing but what is the percentage of abnormal reads versus normal reads. And that's how we call a particular variant allele fraction and then identify the somatic mutations. But I think the other important thing we need to talk about, how do we systematically study these CHIP mutations in the global population? The best way to look at is the global biobanks. We have various global biobanks throughout the world, but one of the biggest biobank we have is established at Vanderbilt, which I'm going to talk about in the subsequent slides, where we have close to 330,000 people whole genome sequenced along with their health information cataloged systematically. So we know that what happened with their in 10 years from now or 5 years from now, everything is systematically cataloged. So that's a huge resource. Along with that, there are other resources as well, but none of the other resources where whole genome sequencing was done. I know there are a lot of initiatives being done right now where the sequencing is being planned. I think one of the best is example, which I was talking earlier, is Genome India, where they have sequenced 10,000 genomes right now, which was released by Dr. RPM Narendra Modi 4 days ago, which is a huge resource in my opinion, because historically we didn't have any established biobanks. This is the first time they have done this initiative, which could be a very good resource for pharma as well as the researchers who are interested in learning about the disease variants we are predisposed to, especially I think coronary artery disease is something all South Asians are predisposed to. What is the genetic variant that's driving that? I think this could be a very important resource. The other one I mentioned, Vanderbilt BioView. It's a biorepository where more than 330,000 patients are sequenced. And we started this initiative back in 2006. And so far, almost close to 20 years, we have systematically got the patient samples. And the way we do it actually is a very, very smart move. So what happens is whenever a patient who comes to Vanderbilt, either in the primary health clinic or in the cardiology clinic or in the cancer clinics, whenever they sign up for the appointment, they sign this consent form called BioView consent, which basically says that we will use a discarded blood. So whenever we draw for blood counts, let's say CBC, complete blood count, or complete metabolic profile, we don't use the entire tube. We just use a part of the tube. The rest of the tube blood is basically as a backup. Instead of repeating the blood draw, we use it as a backup. So a lot of the times what labs do is they just discard it. So what Vanderbilt did very smartly is that, instead of discarding the blood, why don't we take permission from the patient and use that as a DNA source so that we can study genomics in the future? I think which was a very smart move. I think that is something can be done anywhere in the world in my opinion, because we all do complete blood counts for every patient who comes to the clinic. Any procedures they are getting, we get a complete blood counts, and a lot of the times this blood is discarded. So I think we can easily store the DNA from that discarded blood and use that as a huge resource to study genomics. Along with this biobanks, we also have established a formal clinics as well. Just like we have cardiology clinics, we have chip clinics right now in US, and at Vanderbilt we have started an initiative called CHIVE initiative, which basically is clonal hematopoiesis and inflammation in the vasculature, where we have formally established a follow-up period when these patients need to be seen and how to monitor them over a period of time. And I'm actually driving that at Vanderbilt, and we also have a close collaborations with cardiologists at Vanderbilt. And we also have grown this. I think that is something we can talk about ideas of collaboration. So this is what we call the Delta area in US. It's in the near a river bank, where historically there was a lot of pollution in that area. A lot of industries used to dump their waste product into the river, and that led to the huge increase in cancer in this Delta area. This is the Tennessee state, and this is Alabama state, and this is the Mississippi state. The cancer incidence here were historically very high. And right now what we are doing with the community collaboration with the Baptist Health System, we are actually systematically getting blood samples from them, where we are studying how patients are developing blood cancer, and is there a way we can detect development of blood cancer much like 10 to 15 years before using the mutation panel we have. I think that is something can be potentially done, I think, throughout the world in my opinion. And these are the ways and means we use how we recruit patients to our clinics. So anyone without a active hematologic malignancy is included, where we risk stratify into various groups, and then we collect specimens. And each patient, if they develop a cytopenia or a low blood count, we get a bone marrow biopsy to see if they develop MDS. If there is no evidence of MDS or AML, then we systematically follow these patients periodically. I think the biggest question that comes to everyone's mind is, how are we doing this? And I think the answer is, we developed at Vanderbilt a very cheap assay, where it is $5 per sample, which is something it's never heard before. Historically, it's been $400,000 per sample, but we brought down the cost substantially, and right now we are doing about $5 per sample where we can get this information. And this is something a lot of interest throughout US, and we have sequenced about 130,000 samples throughout the US. We got samples from Mass General in Boston, we got from University of California in Los Angeles, UCLA, Stanford as well. So a lot of institutions are sending us the samples because we are doing it at a very low cost. And this is the assay where we have included the mutations which are commonly driven in clonal hematopoiesis. There are about 26 genes. We do targeted sequencing, about 500x depth, and this captures majority of clonal hematopoiesis. So that is the diagnosis. And now talking about prognosis, I think this is probably might have been an interest for a lot of folks in the audience. I think this is the slide I prepared. This is something I updated every 3 months, where you can see that the impact of CHIP is growing every day. Every week I see a new publication about CHIP. The first publications were about the predisposition of blood cancers, but then most recently there's a lot of publications about development of early onset coronary artery disease as well. And there is also recent publications about chronic liver disease as well, which came out in Nature in 2023. And there is also, during COVID period, we found that people who have clonal hematopoiesis are at increased risk of development of COVID-19 as well. That has also been reported. And along with that, we are seeing other chronic health conditions such as type 2 diabetes as well, and blood clots is also another important thing. Along with that, we also seen autoimmune disorders. So I think in short, I think the consequences of CHIP, it's expanding. I think then the biggest question that comes to everyone's mind is this just an association, or is this really a causation? I think that is something we are slowly understanding. There are some mechanistic studies which have clearly shown that it's not just an association, there is a causative factor here. I think talking about the early onset MI, the odds ratio in these two big studies, if you combine these two big studies, the odds ratio is about 4. Some of the researchers might appreciate this. The odds of development of smoking and early onset MI is about 5. So this is close to that. That shows that how significant these CHIP mutations are in development of MI. And those associations are also growing every day. There are a particular mutations can drive aortic stenosis, pulmonary hypertension as well, and there are some studies showing that these particular mutations can cause heart failure. Then the question comes is how this is happening. These are supposed to be blood somatic mutations, but how are they driving all this? I think that comes down to what I call the macrophages, which is what there in the lipid atherosclerotic plaques is a product of monocytes. So what a lot of people have found that the monocytes carry these particular mutations, and when they become a macrophage, they have this inflammatory milieu which drives the cardiovascular disease as well as other conditions such as chronic kidney disease as well. Then shifting gears to talk about myeloid malignancy risk. I think this is where the first CHIP was identified, and these are the different mutations we see in CHIP. And this slide, which shows that there are various risks associated with the different mutations in development of blood cancer. So then the question that came is, yes, we are detecting all these people, but who are the people we need to intervene or we need to follow more closely? I think that is the biggest question, because it's going to be very hard. All our clinics will be filled if we see 10% of world population in our clinics. There has to be a way we can identify who are the individuals who are the highest risk. So there's a lot of research going on right now. I think one thing we are seeing is larger CHIP clones are associated with worse outcomes. One thing I mentioned before, that the WHO set the threshold at 2%. But what we have seen is in people who have 5 to 10% variant frequency, 10 to 20%, or they're more than 20%, the risk of development myeloid cancer changes. It becomes close to 27% here, and the hazard ratio in people who have a larger clones. Then we ask the question, is that the only answer? If we have an individual with a high VAF, can we say that this is the individual I need to monitor more closely and work with my cardiologist to control their other risk factors such as high blood pressure, cholesterol? I think there is more nuance than just a variant allele frequency. We also have seen that it's not just the bigger clone. There are some mutations which have faster growth as well compared to the mutation size itself. Then the question that arose in our mind, and this is what the subsequent slides I'm going to show, is that how can we measure the CHIP growth rate? I think that is going to be the important piece in the entire puzzle about how to follow these patients systematically. And to do that, I think ideally what we would need is blood from someone 10 years apart. I think that's going to be a very hard thing to do. Yes, we have BioView as one of the resource, and we have other biobanks as well. But a lot of the biobanks were started after 2010 or 2015. So we don't have that longitudinal follow-up or longitudinal blood sample collection as well. Fortunately, at BioView at Vanderbilt, we had multi-time points from two different, like 10 years apart or 15 years apart. In few of the individuals, only 10% of BioView had a multi-time point DNA samples. So we actually looked at their VAF at time point 1 versus VAF at time point 2 and see what is causing these mutations to grow in size to develop a blood cancer. So that is something we were able to study at Vanderbilt using 700 patients. At one time point we calculated the VAF, and the second time point we calculated the VAF, and then we looked at the clonal expansion. So what we found is that there are some clones which grow in size, but there are some clones, for example, the DNMT3A clones, they regress in size as well. So not all mutations are growing. There are some mutations which are just disappearing. I think that's where our immunity comes into place, something called immune surveillance, where they see these mutations and our immunity clears them off. But there are some mutations such as the splicing mutations, as some in the audience might know, are important drivers in myelodysplastic syndrome and AML. Usually we consider them as an aggressive phenotype. They do not regress in size at all. They grow in size, which we appreciated in this as well. We calculate the growth rate. As you see this, the SF3B1, SRSF2, which is the splicing mutations, which are the ones which are actually a major determinant of growth, rather than the other mutations such as DNMT3, ASXL1, and TET2. This is an important piece. It's not just the variant allele frequency, it's the type of mutation also matters a lot. Then we asked whether if they have high blood pressure, cholesterol, or any other medical condition, will that impact their growth? And this is what I call chicken and egg problem. Which came first? If the patient with high blood pressure, diabetes, have a higher CHIP, versus the CHIP cause the hypertension, diabetes, or the other coronary artery disease. I think in our study, at least, we found that the comorbid conditions does not have any impact on the growth rate of the clone. It's completely driven by the type of mutations rather than the kind of comorbidities these patients have, which was also proven simultaneously in a recent Nature Medicine paper, came from the UK group, where they also showed that the CHIP mutations predispose development of atherosclerosis. It's not that patients who have atherosclerosis have CHIP mutations. So it's a chicken and egg problem, but I think we conclusively proven that it's a CHIP mutations which predispose development of atherosclerosis. And so this is again the faster growing clones have worse outcomes, which we have conclusively proven, and they also have increased risk of development of a type of blood cancer called myeloproliferative diseases. Now talking about mechanism, I'll sort of go fastly because lot has being studied right now with a very limited understanding, I should say. But one thing we are trying to understand is how can we target the clonal growth. As I mentioned in the earlier slides, the type of mutation impacts the growth, but is there a downstream signal where we can target? Because developing drugs for each and every mutation is going to be very hard. But we need to target the downstream of all the mutations which is there in the DNA. I think that to study that, we developed a technique called PACER, which identifies what is the clonal expansion rate. As I mentioned earlier, ideally we could have done it with variant allele frequency, but variant allele frequency at the two different time points were only available for few patients. Then we asked the question, can we see which are the clones which are growing in size at one time point or at one snapshot? To understand that, we developed this technique called passenger approximated clonal expansion rate. What is this? Basically is a person 1 who is age 70 has a particular clone, and there's a person 2 age 70 has a person as a CH clone, and they have a group of mutations. Let's say that they have 3 mutations, and this particular person has 6 different mutations. So if you have more mutations, then it means that you are acquiring, it's a faster clonal growth compared to people who have slow clonal growth. This is very similar to the tree bark. When we cut the tree, you can count the age of the tree based on these circles. So it's very similar to that. And the more mutations you have, it means that the passenger mutations, the more mutations you have, it means that the faster the growing the clone. And based on that, we can estimate which are the patients who have a faster clonal growth, and then we can see what is the downstream effect of this faster clonal growth. And that is what we did, the genome-wide association study with this data set. Which I'll show very quickly, where we include a cohort called TopMed cohort, which was an initiative done by National Institute of Health, where we did the GWAS on these individuals using the PACER, and we found that all these mutations they converge on a single path which is called TCL1A. This is the downstream of all the mutations, which is very important in the clonal growth. Then this was a hypothesis. Okay, we have a variant which is driving all the clonal expansion. Then the next question that begs to we need to understand is, how this variant is causing the clonal expansion, and is it absolutely this is the variant that's driving the CH expansion is also something we need to understand. And to understand that, we looked at if someone has a particular mutation in this TCL1A, what happens to their growth. And surprisingly, although not surprisingly, we have seen that if you have a particular variant in TCL1A, your clone growth rate, as seen here, is less compared to people who do not have any variant in this particular gene. Then we did a lot of experiments, including the chromatin accessibility, and we have seen that the TET2 mutation, which is one of the common clonal hematopoiesis mutation, it opens the chromatin of TCL1A. So it's a downstream of all. So TET2 mutation requires TCL1A to have the clonal growth rate. And what happens to the variant? If the variant is there, then it completely, the chromatin closes out and TCL1A is not active and there is no clonal growth rate. And we have seen with the expression as well, and we also seen with expansion as well. What happens if we knock down TCL1A, then there is no expansion as well. I think it's very clear from all these elegant experiments that downstream of all the clonal hematopoiesis, TCL1A is the main driver. So right now, our hypothesis is that instead of targeting a mutation to stop the clonal growth, we can potentially target the downstream signal, which is TCL1A. And right now, a lot of elegant studies are ongoing to degrade TCL1A so that we can target all the patients who have these mutations. So this is the entire summary of the TCL1A story. And next, moving on to the mechanism, the management, I think, which is the most important part for all our clinicians. In first talking about the management, I think it is important to look at what are the patients who are at the highest risk of development of myeloid malignancies. Yes, we talked about the variant allele fraction and the growth rate as well. The other thing we need to factor in is what are their blood counts as well. So there are a lot of work ongoing right now. We were also actively involved in developing a particular calculator a clinician can use in the clinic. They can put these mutations, their blood count abnormalities, as well as their medical history, and can we have an output of what their risk is. So we developed a score called clonal hematopoiesis risk score, which can give us, or the patient as well, when you're talking to the patient, saying that yes, you have this mutation, and if you have a particular blood count abnormalities, and the only blood count abnormalities that stood the time is the red cell RDW as well as MCV, and if they have any kind of low hemoglobin, low platelet, as well as low neutrophil count. Along with that, age is one of the other factor, and then the other is about the variant allele fraction as well as the mutation number. And there are some high risk mutations which I mentioned earlier, the splicing mutations is being one of them. So with that, we developed a score. So when you plug in the numbers in this particular scoring system, you get a three different risk status. One is the high risk, intermediate, and other is low risk. If you have high risk, you have about close to 1% risk of transforming into a myeloid neoplasia. So this is something you can act on and counsel the patient as well, that with this blood count abnormalities, with this particular mutation, this is your risk of development of myeloneoplasms. We are actually also developing a similar risk score for coronary artery disease as well, so that we can counsel the patient that you have this mutation, this blood count abnormalities, what is your risk of developing early onset MI, so that though that particular patient can work on controlling aggressively high blood pressure, diabetes, which are also important triggers for coronary artery disease. Then the question that bogs down to everyone is this the entire story, or are there other things we need to consider in determining the risk status? So I published a paper where we actually looked into, along with the mutation, we looked into the chromosomal changes as well, and I actually found out that if we, along with, and to do this, I did an UK biobank, where I found that along with the mutation, you also need to have the chromosomal changes as well to increase the risk of production of transformation to a myeloid neoplasm. Then the other study, which I'm quickly going to go so that we have some time for questions, is that we know the risk of transforming of these conditions into MDS or AML. This is about 0.5 to 1% per year. But what are the people who develop a blood count abnormality? And that is something also we were very interested, which can guide us to make a decision about clinical trials as well. To study that, I actually utilized 3 biobanks, which I briefly mentioned earlier. One is the All of Us biobank, which is the precision medicine initiative from Barack Obama, as well as BioView and UK Biobank. It comprised about 800,000 patients, and where we looked at the presence of CHIP mutations. About 162,000 had CHIP. Then we looked at their blood count abnormalities, like a case control study. What I found is that if you have a more than 5 mutations, your risk of development of blood count abnormality is higher. Along with that, if you have a particular abnormality called a splicing mutation abnormality, your risk of development of a blood count abnormality is also much higher. This is very similar to what is the risk score we developed for the CHIP and sequence as well, sort of goes along with that. And we use that, for someone to develop from CHIP to myeloid neoplasm such as MDS, AML, the intermediate step has to be cytopenia. And that is also something we found out in the study as well. And right now we are planning clinical trials to use cytopenia as a surrogate marker for clonal hematopoiesis prevention trials. Right now at Vanderbilt, a lot of clinical trials are ongoing. Some of them are driven by me and other faculty in cardiology. One such is the targeting inflammation, as I shown in some subsequent previous slides, that inflammation is also one of the core in progression of CHIP clones. Right now we have a study looking at targeting IL-1 beta, which is an important in inflammation, as well as NLRP3, which is also an inflammasome. So right now these 2 clinical trials are ongoing. I want to end this presentation with an interesting study in Europe, which was on with vitamin C, how vitamin C impacts these CHIP clones. In my opinion, this is a very elegant study where they randomized people to get placebo versus vitamin C and systematically collected their blood samples and looked at the outcome. One interesting thing they found that is there was no change in the blood count abnormalities, and there was also no change in the variant allele fraction from inclusion to the end of treatment. But what they found, which surprised a lot of us, is that there's a survival difference in people who got vitamin C versus people who did not get vitamin C. I think this is something surprised a lot of us. And people were dying from a disease such as coronary artery disease, and some people transformed into a myeloid cancer. So we're still trying to understand. This was just, we had a presentation at European Hematology Association. It's not still out yet as a manuscript. So we are still in the process. What drove this difference with vitamin C? I think that begs to the question that there are a lot of medications out there we can repurpose for this clone hematopoiesis prevention trials. I think this is my last slide. I started this presentation with saying the tipping point. I think back in 1944, the first time we found out that DNA is an important molecule in life, and then the subsequent 1953, Watson and Crick discovered the double helix structure of DNA, and then it took about almost close to 40 years for the Human Genome Project to happen, which was started in 1990, and it took about 10 to 15 years to sequence the entire human genome from 5 different individuals, which came out in 2003. And in 2015, I showed in earlier slides about the Undeceased Diagnosed Network, and most recently in 2016, the Barack Obama initiated the Precision Medicine Initiative. I think all these different initiatives have led to a genomic revolution where the cost of sequencing have come down substantially. I think right now, just as you order a complete blood count, you will order a genomic sequencing when the cost is as low as $5 per sample. I think I end with this. My favorite quote from Julius Caesar by William Shakespeare. There's a quote that says that there's a tide in the affairs of men, which taken at the flood leads on to fortune. Omitted, I think all voyage of their life is bound to shallows and in miseries. One such a full sea are we now afloat, and we must take the current when it serves, or we lose our ventures. With that, I say thank you. This is all my collaborators as well as the faculty at Vanderbilt. With that, I'm happy to take any questions. Sorry, I might have ran a little bit overboard. Right at the time.
Excellent talk, Dr. Ashwin. One question. So you have shown that in one of the things you are using a panel where KRAS and TP53 are also part of the panel. Say,
correct.
For example, apparently healthy individual with the somatic variant in one of those genes, how will you decide which organ has the malignancy?
That's a very, very, very good question. So one thing I will say is that KRAS and TP53, they can cause blood cancers, and they can cause, as you know, colon cancers as well, and they can predispose to development of breast cancer as well. Right now, the majority of studies which we did, as well as the panel, is designed to predict myeloid cancers with blood cancers. Then the important question is, what about the other tissues? When we collect a blood sample, we get the cell-free DNA as well, which can come out of the tumor. So a lot of the times what we are trying to understand is that if the patient has a particular symptom, we can go ahead and take a biopsy of the particular tissue. So majority of the mutations we are checking are driven for myeloid cancer, are cause predisposing development of myeloid cancer. But if the patient has, let's say, a polyp, we can look at the sequence from the polyp and see that is there a correlation. And right now, lot of the times what we are doing is we are getting the tissue sample. Let's say if there is a lung nodule, we're getting the tissue sample, and we're also getting a matched blood sample as well, just so that we know where this mutation is coming from. Is it from this particular tissue, or is it coming from the blood?
Sure.
Yeah, I think that's a very, very good question. I think until we continue to find this matched samples, it would be very hard.
And have you also had a chance to look at the mutational signatures, the single base substitutional signatures? And in case you have said that there's a genome-wide associated variant,
Right.
do you see any specific mutational signatures between the three genotypes?
Which three genotypes you're talking
The
about?
three genotypes that is actually driving the somatic mutation, the genome-wide study
The
that you
Jiva
have
study,
done,
yeah, yeah.
Jiva study
Yeah,
that you
yeah,
have done.
yeah. So it's a very, very good question. So we did not see a particular mutation signature because there are so many different somatic mutations which are driving this clonal process. So we didn't see a particular genome signature. But one thing we have seen this is the common variant is a TCL1A, which is the most common variant, which drives all the clonal expansion. But also in TCL1A story, the important thing we have seen is not all somatic mutations cause TCL1A activation. There is some heterogeneity there. I think the most important thing is the DNMT3 mutation, which is not driven by TCL1A. So a lot of the times we remove the DNMT3A and look at other somatic mutations,
Sure.
and which drives the TCL1A.
Sure. Thank you.
Thank you, Dr. Ashwin. That was an excellent talk. And we have learned something new today from you. So how do you think we can utilize the Genome India data now to study the chip analysis and the susceptibility of Indians to different diseases like cardiovascular, diabetes, and malignancies,
Yeah.
etc.?
Yeah, that's
Any
a very, very
suggestion?
good question. I think that's where I think this reference genome, which was done by Genome India, will be a very, very important piece, because I think the one thing we need to understand is 10 to 15 years ago, the cost of sequencing was so high because of the reagents and the manpower needed and all those things. But that has come down substantially. Right now, the biggest puzzle is the bioinformatics skill set needed to call which are the true variants, which is the signal and which is the noise. I think that is something the biggest thing. And lot of the times, the reference genome we use is done from the Human Genome Project, which were 5 Caucasians, 5 different individuals. They got tissue from different organs and they did the sequencing. We don't have any kind of whole genome sequencing from India so far. And there is definitely a genetic variability between Indians and Caucasians. I think that's where we can utilize this 10,000 genomes, where they included 99 different ethnic variety of individuals in the 10,000 genome project. So I think that can be used as a reference genome. And based on that, we in the hospital systems need to systematically collect the blood samples and compare with this reference genome to call which is the signal and which is the noise. And that's where I think once we have the cheap sequencing test as well, where we can systematically identify and correlate with their healthcare like cardiovascular mortality as well as high blood pressure, diabetes, we can correlate very well.
Thank you.
The biggest missing piece was the reference genome. Fortunately, we finally have it.
How do we measure this chip? How do we measure this? How do we test chip?
We did from peripheral blood. We just take the DNA from the mononuclear cells. We isolate the DNA and we do the sequencing. And we do about 200 at a time, 200 different samples at a time. So it takes about 2 hours to do the entire 200 different samples. And then we get the raw files, and we bioinformatician will call the mutations.
So all the genes that you mentioned, that's it.
Yeah, that's it. That covers about 95 to 96% of all chip mutations. There are some rare variants which is very, very low prevalence. So we usually, in order to bring down the cost, we only capture 95 to 96%.
So from the cost, you are saying that from the CBP sample, from the blood sample, we can do the test. How much per patient we can cost will involve for the genomic sequence?
So I think, as I said, the DNA extraction from the peripheral blood, that's a cheap part that we can do it even in India as well. It's very cheap. I was actually talking to one of my friend who has this reagent company. Actually, he was telling me that it's very cheap to do it. It's not the tough thing. I think the tough thing comes is once you have the sequencing reads, what to do with it. I think that's where I think our collaboration can potentially work, where Vanderbilt has a lot of good bioinformatics skill set, which they can do at substantially low cost as well. And they are interested in studying South Asian population as well, because there's a lot of other comorbidities which are specifically associated with South Asians. I think to study that, I think we need to systematically do the sequencing.
And regarding this cord blood bank, is there any help of that cord blood bank in the
That's a very, very good question. So cord blood, I think it's from at birth. Usually a lot of the things I shown in my presentation today, it's the part of our aging. So cord blood, yes, it's an interesting to study, but I think it's not of a good importance for someone with somatic variants.
One more question. Say,
Sure.
as on date, you identify a somatic variant in a patient. How will you decide whether you will have to treat him or wait for the body to clear it off?
Yeah, that's a $1 million question, but thank you for asking that. I think that's where the scores we are developing going to be a big part of it, which we are still refining the scores. They are not perfect, but the scores we have, in my clinic, what I do when I get this referral that we identified a particular variant in this patient, what to do with this information, I usually calculate the score and take all the comorbidities into the picture, and then make a decision saying that yes, this patient we don't need to follow. The variantal frequency is less than 2% or less than 5%, and they don't have any blood count abnormalities, and they are, let's say, 40 years. I don't follow those patients closely because I know that our immune surveillance will take care of that. But patients who are more than 60 with comorbidities, with some sort of blood count abnormalities, not necessarily low hemoglobin, but even if they have RDW or MCV, then I follow these patients more closely. If the patient have even more severe abnormalities, I follow these patients actually every 3 months instead of every 6 months or every 1 year.
Thank you.
But these scores are not perfect by any means. I think we are still refining them.
Dr. Ashwin, great talk. I have 3 questions for you.
Sure.
The first one is regarding PACER. My understanding of mutations are driver and passenger. Driver induces clonal hematopoiesis, whereas passenger does not. When you tell me about PACER saying a passenger mutation based,
Right.
are you referring to that? And in that case, only if a TCL1A works as a co-driver mutation, should it show the thing in the forthcoming hematopoietic clones? Otherwise, is it just the same clone that we're talking about?
Yeah,
So
that's
how
a
does
very, very good
PACER work
question.
there?
Yeah, that's a very good question. So a lot of the times when I talk about clonal hematopoiesis, I mention them as like a single mutation and they are driving it. But in the real world, if you look at it, almost all my patients who come to my clinic, they have a group of mutations. Whether it is SF3B1 or TET2 or DNMT3A. Very, very rarely I see patients with one mutation. Usually one mutation, they don't have a clonal growth. If they have 2, 3 or 4 mutations, then I see that the clone is growing in size. Then what the PACER did is, if they have more mutations, it means that they are growing faster. So that is what the PACER technique is. You approximate the number of mutations and see if they're growing in size. Then we did the GWAS using the PACER technique to see what is that particular variant or particular protein which is driving this entire clonal growth. And that's where we found the TCL1A. So that is in the way I look at it is, yes, these are all somatic variants, but the downstream of them is TCL1A, which is not mutated, which is active in driving the clonal process.
Sure. So the second question that I want to ask you is, in your clinical practice and with your research, how often have you seen the VUS that we commonly come across now eventually becoming mutations of significance?
That's
because
a
in our
fantastic
Indian
question.
population, like with all Genome India coming up, we
Yeah.
will be coming across
Oh, yeah.
significant chunk of mutations which are VUS
Yeah.
today.
Yeah.
So in
So,
your practice, how far have you seen?
I think that's a very, 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 very important question. I think that's something even I personally struggle in clinic as well. We will see a lot of this variants of unknown significance, where we don't have any description in the genome. In the genome, we know the reference genome. We know. So I think that's where I think this 10,000 genomes will help us to understand what are the variants in general population in South Asians. I think that's one thing. We classify a lot of them as variants of uncertain significance or unknown significance because we don't know if they exist in general population or not. I think with these 10,000 genome, I think that will definitely help. But at the same time, what I would say is that we have only a limited understanding of all the variants. Right now, we try to model them using in silico algorithms to say that whether the protein is lost or not. I think if you talk to all the sequencing companies, they say that what they are using is no way perfect, is the best they could do with the available technology. I think in my clinic, systematically still follow them. Some of my patients have actually transformed into a myeloid malignancy when they were actually a variant of uncertain significance. The best example I could think of is back in 2017, the IDH2 mutation, which is one of the common mutations in AML, as you know. The R172, which is the protein change, was classified as a variant of uncertain significance back in 2017-16. Then we knew about IDH2 inhibitors and all those things that changed that, oh no, this is not variant of uncertain significance, this is actually very significant, which can drive the leukemia. So what my personal opinion is that, one, we need to more understand about this variants of uncertain significance, and at this point at least we are systematically need to follow these patients to see the phenotype they're going to develop.
My last question is, and also in relation to the PACER that you were speaking about. When the understanding that we have is with every decade after 30, we tend to acquire somatic mutations, and couple of them become the driver mutation. So for the PACER or even for the biobanking, are you sequentially looking at every decade for seeing this acquisition of mutations and the speed and the growth of it?
Yeah.
So it has to be time-wise rather than a one point.
Oh, yeah.
Are you doing that in a sequential way out there?
Absolutely. That's a very, very good question. So that's where I think, yes, these biobanks are good to understand a snapshot.
Exactly.
Or 2 snapshots at best. But that's about it. I don't think so we can know systematically what's happened in 6 months, 1 year, or 2 years, or 3 years time point. I think that's where the initiative I showed, the CHIVE initiative, we are doing at Vanderbilt, where we are actually systematically collecting the blood samples every 6 months. And we are sequencing it every 6 months. I think that's where the cost of sequencing, given so cheap, we are doing it at $5 per sample. It doesn't hurt for us to do every 6 months as well. So right now, with that data, which hopefully in the next couple of years we'll have some data out of it, which we started in 2020. So far 4 years, we have about 600 patients with systematic every 6 month sample. So I think that will become a huge resource down the line. But you're absolutely right. I think it is important not just look at once every 10 years or once every 15 years. I think frequently looking at what are the drivers which causing the clone to grow in size and what is actually causing the clone to regress as well. I think that is also going to be a very important factor, because if there is a particular medication which can cause the clone to regress in size, I think that is something you can use to repurpose to treat these patients. I think in terms of that, we actually found recently that colchicine can actually decrease the clone to regress in size. We don't know the mechanism yet, which is a gout drug, as you know, and how that can actually decrease the size. But this is something I think we'll only understand if we systematically collect the blood samples.
Thank you.
Thank you, Dr. Ashwin.
course.
That was an excellent interaction as well, not only the talk. And thanks for coming and enlightening us with your work. Thank you.
Thank you so much.